Hi there. Imagine you encounter this lady who is a 45-year-old who comes with history of fatigue. She says she's having severe myalgia. She also complains of weight gain over the past few months. She feels cold all the time. She has irregular menstruation. And she also says that she has noticed swelling in front of her neck. So what do you think this could be? With all these symptoms, it looks like it is hypothyroidism, right? So, what do you think the cause could be? If you have identified this as Hashimoto thyroiditis, yes, that is right. Hello, everyone. Welcome back to this short tutorial from Pathology Made Simple at ilovepathology.com. In this session, let's learn about the definition, the etiology, the pathogenesis, morphology, clinical features, and how to diagnose and complications of Hashimoto thyroiditis. Hashimoto thyroiditis is an autoimmune disease that results in destruction of the thyroid gland, and later, there is gradual and progressive thyroid failure. So three things you need to understand: that this is an autoimmune disease which results in destruction of the thyroid gland parenchyma, which finally leads to progressive thyroid failure, right? And this is the most common cause of hypothyroidism in areas where iodine levels are sufficient. Disease is named after a Japanese surgeon, Hakuru Hashimoto, who actually described the case of thyroid enlargement, which is unrelated to iodine deficiency. He also saw that this particular thyroiditis had a very peculiar features in the form of having lymphoid infiltrates in the thyroid gland, and it was referred to as struma lymphomatosa. It was after many, many years when people started identifying that there is a new entity of involvement of thyroid gland by autoimmune disease. Then, in the honor of Hakuro Hashimoto, they named it as Hashimoto thyroiditis. This disease usually occurs in the age of around 45 to 65-year-olds. Females are predominantly affected, more commonly affected, as in all other autoimmune diseases. Of course, it can occur in children, and this is the major cause of non-endemic goiter in children. So, before we understand the pathogenesis of Hashimoto thyroiditis, we need to look into what exactly you mean by immune system in equilibrium, which means there is a balance between lymphocyte activation and mechanisms of tolerance. So, when these mechanisms of tolerance fail, and that is when we call this as autoimmune disease. So, in case of Hashimoto thyroiditis, there is a breakdown in self tolerance to thyroid autoantigens. First thing we need to know, why does this tolerance fail in any individual for that matter? So, two important reasons as to why this tolerance fail. One is inheritance of susceptibility genes, which results in breakdown of tolerance, and second one is environmental triggers. Okay, it could be infections which leads to tissue damage. So, let's talk about inheritance of susceptibility genes. The most important one being people with HLA-DR3 and DR5 are the ones who are genetically predisposed to Hashimoto thyroiditis. The second important ones is polymorphisms of immune regulatory genes. So when I say polymorphism, it means, a gene is said to be polymorphic if there is more than one allele which occupies that gene's locus within a population. That is what is referred to as polymorphism. So, whenever there is a polymorphism in certain immune regulatory genes like CTLA4, PTPN22, and IL2RA, CTLA4 stands for cytotoxic T lymphocyte associated antigen. Second one is protein tyrosine phosphatase 22, and the third one is interleukin 2 receptor alpha chain. Okay, whenever there is a polymorphism in these immune regulatory genes, that results in genetic predisposition to Hashimoto thyroiditis. The second important one is environmental triggers, right? Let's look into that. It could be infection, any infection for that matter, and it could be dietary factors, stress, and even pregnancy can initiate autoimmunity in the thyroid. So now let us understand why the normal thyroid parenchyma is destroyed in Hashimoto thyroiditis. This is the normal thyroid follicular epithelial cell. Whenever there is environmental insults in the form of infections, in the form of stress, in the form of even pregnancy, it results in damage to this epithelium, to the normal epithelium. So once there is damage to the normal epithelium, that results in exposure of antigens. Normally the antigens are sequestered within the cells. Okay, that's why there is no reaction. Now, because of damage to epithelium, the antigens come out, they are exposed, and once these antigens are exposed, they are taken up by the antigen presenting cells nearby. And these antigen presenting cells presents these antigen to the T cells. And now this patient is already genetically predisposed, right? In the form of having polymorphisms and HLA-DR3 phenotype, HLA-DR3, right? And that results in breakdown of self-tolerance because these antigens are now seen as foreign antigens by our own body, by our own immune cells in a genetically predisposed individual, right? That is very, very important. Even though if you are genetically predisposed, unless and until the antigens are exposed out, there is no autoimmunity. Once they are exposed, that results in induction of thyroid autoimmunity. Now let's see what really happens here. First and the foremost thing is that CD8 cytotoxic T cells can be activated. How are they activated? They can identify the antigens on the surface of the thyroid follicular epithelial cells. These antigens can be presented by the MHC molecule. Once they identify, there is destruction of the thyroid follicular cells directly, okay, and leads to epithelial cell damage, and this is referred to as T cell mediated cytotoxicity. That is the first mechanism. Second one, CD4 T helper 1 cells are also activated, which releases lots of cytokines, and one of the cytokine is interferon gamma. This interferon gamma activates the nearby macrophages, and these macrophages, they just go and destroy the thyroid follicular epithelial cells, leading on to the damage of the follicular epithelium. That's the second part. The third one is the B cells are also activated. Now that the antigens are exposed, the B cells are activated. They get converted to plasma cell to produce more and more antibodies. What are those antibodies? These are called as anti-thyroid antibodies, antibodies to these exposed antigens. And the exposed antigens are often anti-thyroglobulin and anti-thyroid peroxidase antibodies most often. Once you have anti-thyroid antibodies, what happens? All those epithelial cells which have exposed antigen, they go and bind. These antibodies go and bind to those exposed antigens, right? So you have thyroid follicular cells which have bound auto antibodies. Got this point? Now, these cells with bound auto antibodies are identified by the nearby natural killer cell. Okay, natural killer cells recognize these antigen bound bodies, bound thyroid follicular epithelial cells by means of their FC receptor, and then it leads to damage. And this is known as antibody dependent cell mediated cytotoxicity. Okay, it depends upon the antibody, right? So this antibody is identified by the natural killer cells by means of FC receptor here, and then there is cell mediated cytotoxicity. Ultimately, what did we see? We saw the normal thyroid epithelium because of environmental factors. Damage is there, and because this person is genetically predisposed, the antigens are perceived as foreign, and then there is induction of thyroid autoimmunity, leading on to destruction of thyroid follicular epithelial cells. I hope this point is very, very clear. Very important to understand the degeneration or destruction of the thyroid follicular epithelial cells. Because we know normally thyroid follicular epithelial cell synthesizes hormones, right? T3 and T4. What happens when there is destruction? The T3 and T4, initially there may be transient rise, but then the follicular cells are destroyed. So the T3 and T4 synthesis starts coming down. So there is hypothyroidism. And to begin with, these thyroid follicular cells, because of lot of stress by these lymphoid cells and the macrophages, They try to compensate by increasing production of more and more mitochondria. And that is the reason why these cells are enlarged. They have granular eosinophilic cytoplasm when you observe under histopathology. We'll come back to that later when we understand the histopathological findings. So remember, these are destroyed or degenerated thyroid follicular epithelial cells. Grossly, the thyroid is diffusely enlarged, can be nodular, and you cut when you remove the thyroid and cut it, it is pale yellow tan or rubbery, can be formed to nodular in appearance. Microscopically, see, the whole parenchyma, the thyroid parenchyma is infiltrated by inflammatory cells. We can make out that these are thyroid follicles, right? We can identify that there are colloid filled follicles, but then it is not uniform throughout. You can see that there are lots of infiltration. There are variable sized follicles. Many of the you can even see a lymphoid follicle here. Many of the follicles are atrophied, but then these are the ones which are being destroyed, and these are known as Hurley cells. What is a feature of Hurley cells? This Hurley cell is named after German pathologist Karl Hurley, who first identified these degenerating follicular epithelial cells. They are large cells, they have abundant eosinophilic granular cytoplasm, and the nuclei is also enlarged. Okay, very, very characteristic features these are. These are basically degenerated or degenerating thyroid follicular epithelial cells. What are these cells? Hurley cells. Remember, look at this. There can be anisonucleosis. You can see variable size nucleus also. So these are Hurley cells. These are some more, illustrations of Hurley cells. This is hyper view demonstrating the granularity of the cytoplasm. Can you make out these lymphoid follicles nearby? I mean, the infiltration of lymphocytes. There are lots of destruction going on to these parenchymal epithelial cells. You can see lymphoid follicles with prominent germinal centers. If you want to illustrate this Hashimoto thyroiditis in your examination, you have to demonstrate atrophied follicles, which are usually not filled with colloid, because atrophied follicles is basically because of destruction, long-standing destruction, right? Second, you should also identify that there are follicles with Hurdle cell change. That means, right, the epithelial cells larger and granular cytoplasm. The third one, depict lymphoid follicle with prominent germinal centers, and do not forget to show lots and lots of inflammatory cells in this stroma. It could be lymphocytes, plasma cells, and monocytes or macrophages. So at this point, this is how you illustrate Hashimoto thyroiditis. There are variants of Hashimoto thyroiditis. Whatever we have studied so far is the classical variant, but there is another variant called fibrous variant, which is nodular, firm to hard in consistency, where there is severe follicular atrophy because it has keloid-like fibrosis. It is confined within the capsule due to the presence of very, very broad bands of acellular collagen. Okay, and that is called as fibrous variant of Hashimoto thyroiditis. Now, how do we diagnose Hashimoto thyroiditis? Of course, patient presents with symptoms of hypothyroidism. Usually, the thyroid enlargement is painless, and if you subject these patients for laboratory, find the examination, the thyroid hormones T3 and T4 is significantly decreased, and correspondingly TSH is also increased. If you want to find the cause, you can demonstrate anti-thyroid antibodies. Usually the patients will be subjected for fine needle aspiration cytology, where we can easily diagnose Hashimoto's thyroiditis based on the characteristic findings. And the further confirmatory diagnosis is by histopathological examination. Now, what could be the complications? What are all the complications you can expect in a case of Hashimoto thyroiditis? Yes, in the initial stages, when the thyroid follicular epithelial cells are being destroyed, what happens? The T3 and T4 hormones, they are spilled out into the circulation. Imagine all the follicular epithelial cells, all the T3 and T4 are being spilled out. That results in transient hyperthyroid state, right? That is called as Hashimotoxicosis. If there is ongoing insult to the thyroid follicular epithelial cells by the immune system, some of these cells can become clonal, can result in B cell type of non-Hodgkin lymphoma. Once an autoimmune disease, they can also predispose to other autoimmune diseases like diabetes mellitus type 1. It can result in adrenalitis. It can, it can be associated with SLE also, or it can result in increased risk of development of myasthenia gravis, which are all the autoimmune diseases. But then another important association which you need to remember at this point of time is that these patients have increased association with thyroid neoplasms, particularly papillary thyroid carcinomas. So that's all for today's session. If you want to remember one thing about Hashimoto thyroiditis, remember that it is an autoimmune disease. One important feature, if you want to remember early cell change, which are degenerated thyroid follicular epithelial cells. One clinical feature, if you want to remember these patients presents with hypothyroidism. Thank you for watching. If you have liked this video, hit the like button. Do comment if you have any queries to ask. If you feel this video useful, consider subscribing and don't forget to share with your friends. Thank you.